transcribing. Perfect. So I apologize to the Thursday cohort because we're going to back up a little bit and make sure that we go through all of the information. I hate being on camera. Let me hide. And then for Wednesday's cohort, we're going to catch you guys up. We're going to start with depression. And right away, you're going to notice that depression is it is our nation, not one of, it is our nation's number one cause of disability. Sad to say. Major depressive disorder, MDD, is basically characterized by persistent depressive episodes lasting a minimum of 2 weeks up to 5 to 6 months. And this isn't just feeling sad. I know some people, um, use that term vaguely. They'll say, "Oh, I feel very depressed," and they are depressed, but they'll say, "I have major, depressive disorder." But theoretically, this isn't grieving. This is not, I feel sad because something happened or because something is going on. This is beyond that. This is the person that is feeling sad and debilitated, really for a lack of reason. So I use the example and I'll use it again. I had a dog. I love this dog. It was my puppy for 17 years, and that dog died. And it'd been with me for 17 years, and acutely I was very sad. And I wasn't just sad for 3 months, which is kind of the normal grieving time for a pet. 3 months when you think about that, right? I was sad for like 6 months, 9 months. I still am sad, right? I mean, if I think about that dog, I get teary eyed and so forth, and it's hard still to this day. Does that mean I have major depressive disorder? Not necessarily. It's just I'm coping maybe unexpectedly to some people. Now, if you're a dog lover, you probably can sympathize with me a lot and be like, you get that special dog. It is really hard to let go of. So you can see you have to be careful of how you're really looking at depression. People with depression, they're going to be a little bit different because what they're finding is that there really isn't that cause and there is this effect. So they might have a trigger. It might be something like that. They might have a trigger. But more than likely, what they're finding is that their general state of mind, it's just not good. It's not in a good place. They don't feel happy. They're losing interest in what used to make them happy. That anhedonia we talked about before. And if you remember, hedonia means pleasure. So if you're having anhedonia, that's lack of. So, you're doing stuff that used to make you feel good. The example that I use is, you're going to Walt Disney World. Everybody's happy at Walt Disney World, right? But the depressed person goes there and they're just like, man, there's a lot of lines, costs a lot of money. They're just seeing the negatives. You just can't slip out of that feeling of, sadness, hopefulness. Uh, I don't want to say negativity, even though it is negativity, um, because I don't want to give anybody stigma who is depressed, but it is kind of that. It is kind of that. They just can't see the brighter side of things. And I know that if you had sim with Professor Mitchell, she's went through this with you guys. If not, she will shortly. We work very close together in developing these sims and perfecting them. And she's going to tell you that you should talk with these folks and find out what is their daily routine like. Do we have somebody who's waking up? It's late in the day. They're in a dark room. They don't really go outside. They're not really getting any, positive feedback from anyone because maybe they live alone. And now they jump on social media and they doom scroll for 2 hours, and then they get up and then they fight the traffic somewhere if they do go out, and that's negative. And so you got to really look at, what are they doing? Are they trying to make things better for themselves? If not, can they start the day by looking at natural light, by taking some deep breaths, by walking outside and just taking pleasure in the world as we know it? Does that make them better? And it might. So now the folks that are truly depressed, they're not going to get better from that. They're not going to find happiness of that. So just kind of keep that in mind, because sometimes you want to look at these patients and just kind of tell them, hey, snap out of it. It's not that easy. It's not that easy at all for these folks. And in fact, that's something that really upsets them and contributes to their depression, and even makes it worse, because they know they should snap out of it. They feel they want to be normal, right? They want to go have a great time, but for some reason they're stuck here, and they're stuck at this level, and we need to help them cope with that, and possibly treat it. And of course, we can use our ECTs. We talked about that last exam, right? ECTs being useful for depression, transcranial magnetic stimulation being useful, but we're also having a lot of medication success too. So that's why meds are such a heavy part of this exam. So again, depression, you have your anhedonia, your lack of interest of things, decreased pleasure with things that used to make you happy. They're not making you happy anymore. You might have psychomotor agitation or retardation, meaning that you just either feel really restless and you can't get the energy to do anything, or you just are unable to really make yourself do anything. And that's kind of where it goes back and forth. So, at best, you feel like you want to do something, but you just can't make yourself do it. And that's frustrating too. Fatigue and lack of energy. That's probably, I have to say, the number one reason our clients that we see have come to us, because it's affecting their lifestyle, it's affecting their job, it's affecting their relationship with their family, because they don't have the energy to do these things that they should be doing. And it could be something simple like, I'm calling out of work, maybe more than normal, maybe every other week. And, now it's getting to be every week. And, I can't maintain a clean house. I can't get basic daily chores done because I'm just frustrated by them. And it seems that they hang over my head. And that's debilitating, right? That is a cause of disability, because you're not able to really focus on those things. With that, you also get the diminished ability to concentrate and focus, and indecisiveness. And it's indecisiveness to the point of where even simple decisions these folks are failing to make. They might have very frequent reoccurrence of death and suicide. And it's usually not that they just want to have performed suicide. It's usually starts with, I think it would be better if the world just ended, if everything just kind of went away. Maybe if I had cancer, it really wouldn't be that big of a deal, because, I'm really tired of being here. It's kind of that attitude is where it starts. And then from there, it will develop into a stronger suicidal ideation. So these are the things we're watching our patient for. Distressed or impairment socially, again, in the work environment as well. And we want to be very, 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 very careful with anybody who is postpartum. And you're going to learn more about that next term. So that is Professor Dwyer's topic. So I will let her take care of that. But if you ever in OB feel like there is some issues with attachment between mom and baby, please, please, please address that before that mom leaves the hospital. We need to get her some help. It might be as simple as having her family aware of these things, and having more resources available, making sure that she's relieved after taking care of that baby for a few hours and so forth, making sure she has a supportive partner. But we definitely do not want to discharge her knowing that she could possibly have postpartum onset of depression. How do we assess depression? There's lots of different scales. Again, pay attention in your sim, because you'll use some of those. The Hamilton Rating Scale does look at 17 different areas that can cause depression, or how it affects your life. And then Beck's. Beck's tends to be a really easy, simple antidepressant or depression scale, and it's used pretty commonly as well. So a little bit on depression. Now we also have different types of depression. Seasonal affect disorder, I'm just going to touch on this in case we get a test question on it. Seasonal affect disorder. This doesn't affect us a lot down here in Florida because we do have sun all year round. However, if you came from the Midwest, if you came from some of our eastern states, even, you are going to go through periods, Alaska, yeah, definitely Alaska, where you have decreased light, natural light. That alone is enough to make some people depressed. And how we treat it is we use phototherapy, we use UV ray light, and it looks like a mirror and it has lights around it. They spend some time in that light every day, and it decreases SAD or seasonal affect disorder. So if you think about how important lighting is, just light, period, being outside, being in nature, very, very important for our mental health. Another type of depression that exists is called persistent depressive disorder. Dysthymia is what it used to be called. And PDD basically consists of a chronically depressed mood for most days or more days than not over 2 years. So basically, I always think of Winnie the Pooh, if you remember watching that as a kid. You know how you had Eroy? Eroy had PDD. He had persistent depressive disorder. Every time you saw Eroy, he could be at a party, he could be anywhere, and he was just like, okay, everything's, like he just was never the happiest character, right? So, yeah, that's how this person's going to kind of present themselves. Even at their very best, they tend to be still exhibiting some depression. A question we get often is this bipolar type 2? It could be, but again, there's a very fine line between those two, and we'll talk about that next exam. So actually, I just double checked. No, we will talk about that later. Never mind. We'll talk about that later. But yeah, bipolar type 2 has a lot of depression associated with it as well. So, but the provider will know those differences. We don't need to worry about that in nursing. The diagnosis can be made in children. Early onset is before the age of 21. Late onset is after 21. So yes, you do see children go through this. In fact, when we get into childhood disorders, you're going to see that unfortunately, that is a huge concern in mental health right now. We do not know where we're going to go with this because we have record numbers of children coming in with depression, which is really sad. Another type of depression that exists, again, is with the hormonal system. Again, this is your PMS. It is also referred to as PDD, but premenstrual dysphoric disorder, cluster of symptoms around your period, usually the week before. And this is going to include mood swings, irritability, depression, anxiety, feeling overwhelmed, and difficulty concentrating. It is a very real thing. So it is something that we talk about. We actually can diagnose that and help folks out with that as well. It might be something like a very mild antidepressant that they're taking all month, like an SSRI. But yes, that does exist. PMS is very real. Phases of depression. Depression usually comes with what we call an acute phase. That's between 6 and 12 weeks. You have very severe clinical findings of depression. We watch for suicidal ideation during that period. Of course, that's always a concern. And it's always a concern with the first 4 weeks of all SSRI medication as well. So black box warning there, especially for teenagers. I'll say that a couple of times because it's really important. So you'll hear me talk about that again. Yeah, if you need a one-to-one, get a one-to-one in the hospital setting. So that's, somebody that's watching them consistently 24 hours a day and night. It could be a camera, could be via camera, depending on your state and your policies. Our goal is the reduction of the depressive manifestations. So, our goal is to help that patient feel better, have more energy, have some pleasure, be able to participate in their ADLs, and then hopefully uh, be part of society again. And we want to prevent relapses as well. The maintenance phase that can last for years for these patients. And again, our goal is really just to reduce the depressive episodes. Why does depression happen? There's no one size fits all here. It's usually, I think, a mixture of all of these things. You have the genetic component, you have the biochemical component, you have the physiological component. You might have medications that are attributing to depression. You might have neurological, electrolyte, hormonal, and nutrition disorders, and those can also contribute into being depressed. And then, of course, you have all the external things that actually do happen in this world that sometimes are very depressing as well, depending on your lifestyle. Psychosocial theories, the psychoanalytic theory is analytic theory, sorry. Depression is caused by the loss of an object that was loved. And yes, of course, that does cause depression. But for some people, that will contribute to a depression that they can't get out of. And that's what the psychoanalytic theory is going to focus on. And they're going to be using a lot of CBT and hopefully reshape some of those feelings for those patients. The learning therapy theory, that is basically somebody who's had a lot of failure in their life and they just kind of give up because they're just not a very successful person, or that's how they're viewing themselves. And that's what the learning theory basically consists of. You have the object loss theory. This is basically something where, and you'll learn about this when you get into pediatrics with Professor Dwyer, but not having a strong attachment in the early periods of childhood. They do believe that that can cause some lifelong depression. So, cognitive theory, this is basically the basis for negative expectations of the environment, self, and future. So, that is also a theory. And then the transaction model, which is stating that it's a combined effect. And I think that's kind of what most um, providers are now practicing. It's not just a sole event. It is a combination of many things that happens that causes this biochemical imbalance known as depression. For suicide, we talk about suicide a lot, mental health, because of course it's a psychiatric emergency. And we want to make sure that we are always assessing and addressing it if any ideation occurs. How do you address suicide? You want to establish a therapeutic relationship. You want to be open and honest and direct in asking questions. Have you thought about harming yourself in any way? Have you ever felt life's not worth living? Have you been thinking about death recently? Do you think about suicide? Have you attempted suicide? Are you going to plan to attempt suicide? If so, what is your plan? And do you have a means to carry out that plan? By talking about suicide, you are not hasting suicide. You are simply making that patient, giving that patient an option to come forward with that information and share that with you. So please always ask. I know some nurses are uncomfortable doing that, but it's extremely important. What do we do for the depressed or suicidal patient? Watch them carefully, very carefully. Put them on a one-on-one or frequent checks if you need to. Um, Remove items of harm. That could be something as simple as a hanger. I told you about the guy that was saving all the plastic around his silverware and made a noose around plasticware and made a noose for himself out of it. These people can be really creative. So you have to be twice as smart, right? You really need to look for pocketing. What is pocketing? That is where they take their med and they pretend that they took it in front of you and then they spit it out. They stick it under their bed and they save all of those meds and then they try to overdose on them later. There's a really good movie out about depression called Girl Interrupted. It is I think Professor Mitchell might show you that movie if she gets time. If you remind her, she probably will. But yeah, that movie is about somebody who was very depressed, and you'll see some of the things that they come up with, which unfortunately do happen on mental health floors. Watch folks that have stopped their meds or have had a medication change or have just started a medication. Again, especially teenagers, there's a black box warning on all SSRIs. And that means that you have to watch anybody who is a teenager that's starting an SSRI, because what happens is they might have, remember, depression takes away your energy, but they still might be suicidal. And one of the first things that starts to happen when you know your medication is starting to kick in is usually the side effects happen right away. So that's kind of sad because you're gaining weight and then that's never fun. But then you get a little bit more energy. And because this person never had the energy to actually carry out their suicide plan, now they have the energy. So that's why we have to watch them very carefully when they are starting SSRIs. Be vigilant, advocate for your patient. Antidepressants basically fluctuate the neurotransmitters in the brain. They pretty much increase the reuptake of the neurotransmitter. And what that means is instead of just sending the neurotransmitter response through the brain, we block the receptor and it basically bombards that receptor with that recycled serotonin or the recycled dopamine or whatever we are using in that particular medication. And by blocking it and not just letting it go through, we get it more of a feel good feeling. So that's what SSRIs actually do, and other antidepressants. So we'll be looking at those next here. And we're going to start with tricyclic antidepressants, or TCAs. We try not to use these as much anymore, but we do use them. And if we do use them now, it's for other reasons usually. But you will still have some of your elderly population on these medications. And now we swab the cheeks and we get people's DNA, and we're able to use that DNA to find out what medication would work best for them. And once in a while, that is a tricyclic antidepressant. Why do we stay away from them? Because they can be lethal if you overdose on them. I believe this was the one Marilyn Monroe allegedly overdosed on. I want to say it was amitriptyline, but I'm not positive. But hopefully that'll help everybody remember that they're easily lethal if you take too many. So, of course, that's why we don't want to hand them out to anybody that's super depressed, because they can usually figure that out. Amitriptyline, we still use it for sleep in lower doses. So you will see that with a lot of your patients that are older. So I would just kind of be familiar with these. And again, they all end in mine for the most part, INE. They have anticholinergic side effects. Everybody's familiar with that. That farm question has been around forever. Dry mouth, can't pee, can't poop, can't concentrate, and my mouth is dry, right? They do have possible toxic effects, and that is going to deal with the heart. So when they are first starting these meds, we will put them on a telemetry unit and monitor them for that. They also have the risk of damaging the liver and renal function. So we have to be very careful, and we need to watch our LFTs and our liver enzymes and our creat, BUN, glomerular filtration while we're using these meds. I'm sorry, I switched to SSRIs and I didn't even realize I did that. Sorry, guys. Okay, SSRIs. Serotonin reuptake inhibitors. It's been a long day. I've been teaching all day, so I apologize. Kind of going like crazy from looking at PowerPoints here. So SSRIs, these are going to again block that neural uptake of serotonin and recycle it, right? These are the ones we have to look at. We got to look at labs. So usually when we put somebody on these, we're going to ask them to come into the office in 2 weeks and then in 4 weeks and make sure that their labs are all corresponding appropriately. These are very, very, very popular. Back in the 90s, we were throwing everybody on these medications. Now we use them a little bit more sparingly. We're also using them more and more for anxiety. And if you remember when we were talking about substance abuse and Xanax, alprazolam, benzodiazepine, those types of medications, we try not to prescribe them for anxiety anymore because of the addiction factor. Yeah, the rap star that was taking like 100 of them a day or some ridiculous thing like that. So yeah, we do give these out for anxiety in low doses. Citalopram and escitalopram or Lexapro is a very popular medication. Both of those are very popular medications for anxiety. And then you have the fluoxetine, that's the Prozac, sertraline, that's your Zoloft, very, very popular as well. Luvox you're going to see out on the market too. So know these, be familiar with them. They end in the 9 are INE, and then the PAM, PRAM. So hopefully you can try to remember that they fit into this SSRI class. What is the thing you got to remember about them other than watch your renal function, watch your liver enzymes? Can't take them with MAOIs. We'll be going through that in a second. And you have to be careful for serotonin syndrome. Now, serotonin syndrome comes from SSRIs, but it's very similar to your neuroleptic malignant syndrome. Remember when we talked about that with schizophrenia? Almost the same thing, but that one was from antipsychotics. This one is from SSRIs. High fever, you're going to have tachycardia, you're going to have abdominal pain, diarrhea, diaphoresis. What else did I miss? I think I got them all. And usually what happens is too much serotonin is in the brain. And that could be brought on by taking too much of an SSRI, too much of a good thing, not good. Or you're taking an SSRI and they're taking another type of polypharmacy where maybe they're taking an opioid because they had surgery, or they're taking something else that is producing serotonin for them. And now they have these receptors getting constantly bombarded, and the body does not like that. So this could be an emergent type condition because, again, you got the tachycardia. You can have some delirium as well. And these manifestations can also induce hyperprexia, cardiovascular shock, and death. So definitely dangerous, and you have to watch them. Serotonin, norepinephrine reuptake inhibitors, or SNRIs. These are still out there. Some people have really good luck with them, so I don't think they'll ever totally go away. Venlafaxine, and duloxetine. And they also end with the INE, right? So antidepressants there. The only really bad thing about these is we try not to put people on them because they go through what's called discontinuing syndrome, meaning that they get this like head zap type feeling. Usually it's when they move their neck and it feels like an electrical zip or zap. And it's really problematic for the patient. They do not like that feeling at all. And we actually have a couple of patients now that we're seeing because they can't get off their Effexor, and they probably never will because they just do not like that head zap feeling. So they have chosen actually to stay on the medication to prevent that. So it's kind of sad when you think about it. MAOIs, this is your monoamine oxidase inhibitors. And again, you learned about these in Pharm. Just a reminder that they are used for depression. We try not to use these because, of course, you can't have anything with tyramine, and that's all your aged food, because that could be lethal with a hypertensive crisis. So they're still on the market. They're still out there. These are foods with tyramine, but basically it's anything that's aged. So if you think anything that has to be fermented, anything that needs to sit to get better is going to create tyramine in it and cause problems for the patient. Other treatments for depression, we've had great results with ECT when other meds aren't working. That's often something we will fall back on. We talked about transcranial magnetic stimulation, the deep brain stimulator, or the vagal stimulator. Those are working for depression very well too. And of course, your therapies. Lastly, included on this exam, we have bipolar 1 and bipolar 2. So they're involving depression. With both bipolar 1 and bipolar 2, you're going to have a depressive state. The etiology is pretty much unknown. They believe it's genetic, or there's a huge genetic component to it. What is bipolar type 1? Because I know a lot of people will say, oh, I'm bipolar. Like they don't even understand what being bipolar is. It is very common. It's probably underdiagnosed. And what bipolar type 1 is it involves mania. So you feel great. That's what mania is. You feel great. You're flying high. You're talkative. You have some grandiosity. You might be involved in risky behavior, and that's where this is going to come into play. Usually they're using a lot of makeup and they're flamboyantly dressed, and you can really spot somebody who's truly bipolar. They are very narcissistic, just like all into themselves, right? And what makes them bipolar is that this is going to cause some activities that are risky. A lot of it's sexual based, so they might have many sexual partners during this time. They might spend all their money, go on a shopping spree, not pay their bills and buy clothes or something. I don't know. They might go gamble all their money. They're doing something that's taking a lot of risk and debilitating their life. And then it's followed by a crash with severe depression. A lot of times they have ADD, ADHD on top of it all. So, that might be a component as well. So what do we do with bipolar? And bipolar type 2 is just the depression, but they are not actually manifesting this mania. They might have, if once they get that mania in there, we call it type 1. Okay, so somebody asked me, and this is a very valid question, what's the difference between depression and bipolar type 2? Really, it is just simply a difference in diagnostics. I would leave that up to the provider. We don't need to know that in our realm. But yeah, definitely a very fine line between bipolar part 2 and the manic depressant. So don't worry about that for our situation. Why do we stabilize mania with bipolar type 1? Well, again, think about what mania truly is. It's not just feeling good, because of course we want people to feel good, right? The problem is that they're involved in this very risky behavior and they're really not coherently thinking these decisions through, and that's going to cause the crash, and it's also going to cause problems in their life, right, because of that mania. What's the number one med we stabilize them with? Good old lithium. Yeah. Actually, Vraylar is out, and that probably is going to take the place of lithium because, as you guys know, lithium involves frequent blood tests. Yeah. Good luck trying to get somebody in for frequent blood tests when they're severely manic. They don't like to come in. In fact, a lot of them will stop taking their meds because they feel so good, and they don't see that crash coming if they don't slow their mania down. So that is a problem. Lithium is the number one med that you're probably going to get tested on because that med's been around forever. It's kind of like our sacred cow for bipolar. So I would definitely know that one. But again, what is our treatment for bipolar patients? We will keep them safe while they're in this manic state because, again, they're not thinking right. They're not thinking right. Protein and finger foods, stuff they can grab for nutrition because they don't like to stop and eat. In fact, a lot of them will lose that appetite while they're feeling this mania. We'll watch the mood and the sleep patterns. We'll speak slow, set limitations for this patient. Decrease stimulation. And then, of course, if they're very, very depressed because now they've crashed, we want to, maybe consider one-on-one and medication for depression there. So again, medication, mood stabilizers are used. Lithium, the one that's going to be tested on, and that involves frequent blood testing. You need a level of therapeutic level. 0.6 to 1.2 is the traditional level you're going to see in most textbooks, ATI and NCLEX. A lot of providers want to go lower than this because, of course, you'd never want to risk that toxicity. What happens with toxicity with bipolar? With lithium, it's a salt-based medication, so you can't fluctuate your sodium. Otherwise, you're going to run into sodium channel issues. You guys know from MDC2 that can cause confusion, seizures, coma, and death. So it's really important they stay hydrated and they do not fluctuate their sodium intake. Toxicity from lithium can cause diarrhea, nausea, tremors, vomiting, tinnitus, and ataxia. It can also run into major life-threatening conditions as well. So we will tell our patients that they're starting to feel nauseous, and they're usually really good at identifying this because they'll say they do not feel good, even with mild levels of toxicity. They notice it right away. So they'll come in and we will stop their medication. We'll titrate it according to their labs until they feel better. Weight gain is very common with lithium as well. Other meds, just to consider, we can use our anticonvulsants for bipolar. So the action of the treatment is really unclear with that, but they do work. Carbamazepine or Tegretol is good for rapid cycling bipolar disorder. Some people are rapid cycling. They literally will go from mania to depression. I mean, very quickly on you. Valproic acid, a Depakote, that if they're on that, we need another form of birth control. Lamotrigine, call MD if you miss more than 5 days before you restart it and report a rash. That could be possible Stevens-Johnson syndrome, which is very problematic. So if I took time to write something next to the meds, that's probably for a reason, FYI. So topiramate, antipsychotics might also be used as well. And then, of course, SSRIs. So this leads us we'll just kind of review what is going to be on our next exam. I'm not reviewing it. I'm not allowed to review it. I'm just telling you the categories of topics. So we have dementia, delirium, substance withdrawal, schizophrenia, bipolar, and depression. So that's what you will see on your exam. I believe if you're tested with medications, it would be the ones that are on this particular PowerPoint. So hopefully that will help. I would definitely review serotonin syndrome, very similar to neuromalignant syndrome. But of course, serotonin syndrome is referring to your depression medications, where neuromalignant syndrome is a phenomena caused by your antipsychotic medications. Let's see. Pay attention to anything written next to the medications on the PowerPoint. Hopefully, that'll steer you into some correct answers. Read your questions carefully. I will be doing a SLS. It is optional. Hopefully, we'll get a couple people to come and scribe, and maybe they can share that information with the cohort, or even if they want to take notes, maybe I could post the notes that they take on Blackboard. I think I could do that since I would not actually be developing that. So we have some options there. I think I know this is a hard exam. Students have told me that in the past. So please, do your studying. Anxiety, that's another one. I know we did that project in class, but know how to talk somebody down if they're anxious. That's very important in nursing, period. I believe I have a supplemental PowerPoint. You guys can just read through on anxiety if you want to. But that's always good information to know, period. So please bring questions to SLS because I have to try to address questions. So that would be a really good thing to think of if you know somebody that can go Tuesday, because I know a lot of you have clinical, but if you know somebody that can come, pass them some questions and we will address those. Hopefully this will help. I know our class is just not long enough for mental health. I try to talk as fast as I can, but at the same time, I am here if you need any additional support. I want to see you guys be successful. I'm not, an instructor who wants to fail people. I want to see you guys succeed. So please reach out to me if you have any problems or concerns. And I will see you Tuesday, Wednesday, or Thursday. You guys have a great day.